Good evening, everyone. I'm Dr. Carrie Brenner. I'm a palliative care physician here at Stanford and chair of the Jonathan J. King Lectureship Committee. On behalf of the Stanford Center for Biomedical Ethics, welcome to the 31st Annual Jonathan J. King Lecture. It is particularly meaningful to greet you this evening, since this is the second year in a row where the lecture is being broadcast to an international audience. Last year, we reached thousands of viewers, and this evening we hope to do the same. Thank you for joining this momentous annual event. Before I introduce our speaker, I'd like to give you a brief background of the history of this lectureship and Jonathan King himself. Jonathan King was a gifted computer scientist by profession and a philosopher, but above all, he was a humanist with a deep concern for the dignity of all individuals. In 1991, 3 weeks before dying from cancer at the young age of 41, Dr. King defined key messages that he wished to impart to the medical community through this lectureship. He emphasized the importance of empathy with patients. He also highlighted the need to provide patients with hope, comfort, and a measure of control. Thus, the Jonathan King Lectureship was established here at Stanford, and for the past 31 years, this series has featured superb medical humanists from around the country. It's become an integral part of Stanford Healthcare's mission to enhance patient care and the human elements of medicine. Every year, we show a brief video presentation of Jonathan King so we can remember both who he was as a person and the vision that inspired this annual event. So let's pause together and look back to over 3 decades ago with the following photos and personal reflections from Jonathan King himself in this video.
I have a wife whom I love very much. I have 2 boys who are about to turn 6 and 12. I spend a lot of time with them. I'm working on my projects as much as I can. And this I consider to be a very important activity also, because there are some things that I learned throughout this experience about what's important to me as a patient when you cross that line, what you need to do, and what the medical staff and your wider support groups and everybody else can do to help or to make things worse. I think that's really the important thing. I think the main one is just common sense. And that is to empathize, to put yourself in the shoes of your patient as much as possible. Many of the things I'm going to say really lead back to that principle. And I know that flies in the face a little bit of the training and professional detachment. And believe me, I appreciate how important it is for a doctor, especially an oncologist, who has to deal with patients like me, who they feel, with all their scientific training, is going to die, and it won't be very pleasant. And they have to go home at night and deal with their 6 and 12-year-olds and everything else. And that's essential, and I don't begrudge them that at all. But they really have to put themselves in your shoes as much as they can and understand what's going on with you. There's a line that divides people who have passed over into the condition I'm in from everybody else. I can't really put it into words. I think you understand what I mean. In a way, there's no way that I can convey to you this feeling of the death sentence and how it changes your life. It's something you'll probably hear many times in your career. But you just have to appreciate that that's there, and that as far as possible, get as close to your patient as you can. Second thing, and also very important to me, in this kind of situation, I'm talking about a situation where the odds are really very poor, where your scientific training says from day one, a reasonable thing to do in your case would be just to take narcotics and go fishing. And that was, in fact, suggested to me on day one and throughout. But, you can stop. You don't have to do this. But I think the second point I'd like to emphasize is how important it is for the doctors, the medical staff, to foster a patient's feeling of control and of hope to whatever extent you can.
Hearing those reflections from Jonathan King allows us to recall what's most important when patients are suffering from serious illness. Although that video is from decades ago, Dr. King's emphasis on empathy and putting ourselves into the shoes of the patient is such a timeless principle. It reminds us how life is so dramatically altered when we are at the face of mortality. In many ways, the COVID-19 pandemic has allowed this type of empathy to deepen. In so many ways, the pandemic has shattered that line that Dr. King refers to, that line between us, the healthcare professionals, and them, the sick patients. This line has broken down by our collective vulnerability in this pandemic and simultaneously revealed healthcare disparities. This is one of the many insights we are going to explore this evening with our esteemed speaker, Dr. Betty Ferrell, as she illuminates the ways that the COVID-19 pandemic has remodeled how we approach serious illness care. And now it is my distinct pleasure to introduce Dr. Betty Ferrell as our 31st annual King Lectureship speaker. Dr. Ferrell truly is a luminary in our field. She has been in nursing for over 44 years and has focused her clinical expertise and research in pain management, quality of life, and palliative care. Dr. Ferrell resides at the City of Hope as their Director of Nursing Research and Education. She is a professor, a fellow of the American Academy of Nursing, and has nearly 500 publications. Dr. Ferrell is principal investigator of the End-of-Life Nursing Education Consortium and also is the co-chair of the National Consensus Project for Quality Palliative Care. In addition to her PhD in nursing, Dr. Ferrell completed a master's degree in theology, ethics, and culture. With this expertise, she has authored 11 books, including the Oxford Textbook of Palliative Nursing. Dr. Ferrell has been named one of the 30 visionaries in the field by the American Academy of Hospice and Palliative Medicine, and also is an elected member of the National Academy of Medicine. Beyond these innumerable accolades, Dr. Ferrell is a treasured mentor and colleague. I recently asked an esteemed palliative care researcher to share what comes to mind when she thinks of Betty Ferrell, and she replied, "Carrie, a sentence or two cannot do justice to the wonderful, caring, thoughtful, pioneering, and compassionate individual that is Betty Ferrell. She is an amazing researcher and visionary in our field. Thousands of nurses are now better able to provide compassionate palliative care because of Betty, because of her research, her advocacy, and the educational movement that she envisioned, pioneered, and now has maintained for over 2 decades. Honestly, there really is no one whom I admire more as an academician, researcher, mentor, and overall wonderful and kind human being." On a personal note, beyond all those professional titles, Dr. Ferrell actually recently told me that her favorite title of all is Nana. She treasures being Nana, a grandmother to her 2 precious grandchildren. I instantly chimed in and shared with Betty how I called my own grandmother Nana when I was growing up. And now my own mom is Nana to my 4 young children. Betty replied and said, Carrie, there it is, your most important work in the world, loving those children of yours. I share this with you tonight because this is the essence of who Betty Ferrell is as a person. She's nurturing, generative, and caring, both in her personal family life and also in the ways she has expanded those virtues to her professional family, reaching our entire field. I am particularly enthusiastic to hear Dr. Ferrell's reflections this evening on the future of palliative care after the storm, as she highlights the many ways that the COVID-19 pandemic has reshaped caring for patients with serious illness. Dr. Ferrell, thank you for being here with us tonight, and we look forward to growing from your shared wisdom.
Hello, and thank you, Dr. Brenner, for that very kind introduction. I'm so very glad to be a part of this lectureship, and I remember from the moment I was first invited to participate, what a great honor that it is. I so wish that I was there with you in person. I have so many good friends and colleagues at Stanford, and I had looked forward to being there with you in person and having the opportunity to meet even more friends and colleagues. However, I think this lectureship represents what we all know to be true, and that is that our care continues, and our commitment to improving palliative care certainly continues. And so I'm very, very happy to be here with you virtually and look forward to a time where, again, perhaps we can meet in person and share even more about the passion that we all hold for improving palliative care. In thinking of this lecture, I thought that perhaps it would be very timely to reflect on this incredibly challenging time that we all face. And thus, I have prepared this lecture, entitled it, The Future of Palliative Care After the Storm. Now, I think all of us would say that we feel that, for the most part, we are still living in the storm. Certainly, the numbers of cases continue. We know that surges and new variants of the virus have continued to make this a most incredibly challenging time. And probably for many people as healthcare providers would say that right now they feel more exhausted, more depleted than ever. We all hope to see a better time, real beyond the storm in the months ahead. But for now, it is an important time for us to reflect on the lessons that we have already learned from the pandemic, and particularly to think about what it means for us in the field of palliative care. I've heard so many colleagues say, well, the people who weren't convinced about the value of palliative care before COVID certainly have become some of our greatest advocates, because I think it is quite true. During this time of the pandemic, a time that most of us could never have imagined within our lifetimes or careers, it has been absolutely true that our field of palliative care, caring for people who are seriously ill, supporting their families, supporting our colleagues, has been a very, very critical time. And so what I would like to do now together is to reflect on the future of palliative care. What are some things that we have witnessed so far, and how can we begin to think about the time ahead after the storm as a way that the field of palliative care can grow, and perhaps the entire healthcare system will have learned some important lessons about how we best support patients, families, and ourselves as the clinicians providing serious illness care, and also particularly care at the end of life. As I think about the things that I've witnessed, I think very much about the barriers between us, the healthy professionals, and them, the sick patients. Because as we came to know COVID, certainly in the immediate days or hours, if we can all remember back to those earliest times when we did not have protective gear, when clinicians were entering the workspace with no masks, no gloves, no barriers, that perhaps for many of us, even those of us who have been in healthcare for decades, felt a vulnerability that we had not felt before. In so many ways, COVID really changed that paradigm between us, the healthy, and those people who are sick. I began my career in 1977, and so soon after my career, I began to witness the AIDS epidemic. And I can remember in some of those early days, before we really understood the transmission of AIDS, having that same sense of vulnerability. And yet, in COVID, we know that vulnerability has continued, that many of our own colleagues, perhaps our closest friends and people we've worked with for many, many years, in fact, became the patients. And what an overwhelming time that was. I think even those of us in palliative care who on a daily basis care for people who are very ill and people who are dying tend to have that protective veil of, this is not about me, I'm healthy, I'm going home to my family. And yet that thin veil began to appear, and we realized there was not a thick wall. There was, in fact, a very thin veil that protected us from those who were our patients with COVID. I began to witness, and I'm sure many of you can remember in those early weeks and months, that every patient who survived and left the hospital, there was great celebration. And part of that celebration that I observed is that for every patient who had in fact survived and left the hospital, there was a message for all of us as clinicians of hope that we too would survive this pandemic. Probably many of you remember when you rolled up your own sleeve to get your own first injection of the vaccine, and what a tremendous release. I know for myself and so many colleagues, we found ourselves being vaccinated and at that moment perhaps burst into tears, realizing how vulnerable we had been. And so this has been a time for us, even as palliative care providers, to think about what vulnerability means, to think about what it really feels like to be as vulnerable as the people that we serve. There are many things that we can learn from that experience, that certainly each of us perhaps found ourselves in the place of the patients that we have served, that perhaps we would be the next to be having a family conference, that when we left home in the morning, perhaps we would return also now entering the world of the sick. And so from these experiences, we have valuable lessons in empathy. I think as palliative care providers, we have also been reminded that we are part of the bigger global healthcare system, and COVID has exposed in many ways the brokenness of that healthcare system and the many, many disparities. We watched through the media, we watched images of those people who perhaps were the most vulnerable of all. The number of people in nursing homes who we realized were so incredibly vulnerable. They did not have advocates available to them. People who had chronic illnesses that made them even more likely to get COVID. We witnessed images, such as in the bottom right picture of the screen, you see this family member standing outside the room of a long-term care setting to be able to wave and perhaps speak to her loved one that was inside. I had many times during the pandemic that I really had to stop and think about my own career in palliative care. It came to me that all of the things that I'd been advocating for over my 44 years now as a healthcare provider, that in palliative care we want family-centered care. We want families to be present. We want people to be able to be safe in their own homes. We never want people to die alone. All of the things that we had advocated for in palliative care were suddenly really threatened. How could we continue to promote the most compassionate, person-centered care when we now were all in protective gear and in environments that really threatened the principles that are really our core values in our field of serious illness care? There's been tremendous amount of attention across professional and lay media about this reality of all of the problems that have emerged as we've seen people who are most vulnerable of all. This is from a paper talking about the inequalities in the American healthcare system. And this phrase of disease and death have long been recognized as reflections of the social fault lines in a society. For palliative care, we began to realize, too, that there were tremendous fault lines, that our ability to serve the most vulnerable, to make sure that hospice and palliative care find their ways into the communities that are least served by health care, these things become even more prominent as we faced COVID. And for us in palliative care, this is our time to continue to be advocates, to remember what we have witnessed in the most vulnerable, and to see the fault lines that we have found and how we as a palliative care community can be a part of the global efforts to now advocate for true healthcare reform. All patients deserve the highest quality of care, and we in palliative care can advocate for that to be a reality. Again, I think about all of our work in international aspects of palliative care. As we look at this image of this map and we read these words, the virus is ruthlessly exposing the gaps between the haves and the have-nots, both within and between countries. It finds a fertile hunting ground when more than half of the world's people lack essential health services and have little or no social protection. About 100 million people are being pushed into extreme poverty because they can't afford health care. One of my key projects over the last 20 years has been our End-of-Life Nursing Education Consortium project, or LNEC. LNEC started in the year 2000, and shortly after we began our work in the United States, we began to meet and collaborate with people around the world. In 2019, we had the great opportunity to celebrate a milestone for us, which was that LNEC at that time had entered our 100th country around the world. It's been my tremendous, tremendous privilege to travel around the world and to be in many of these countries and to meet our palliative care colleagues in Africa, in Eastern Europe, throughout Asia, around the world, and to see the absolutely amazing work that they're doing. I am humbled every day to know that my palliative care colleagues around the world face far more obstacles than I can even imagine during the course of my day. The same was absolutely true as the COVID pandemic began, that as I began to interact with my colleagues around the world and we began to develop and share resources to help specifically with palliative care and COVID, I was reminded of my colleagues in India, for example, in Eastern Europe, throughout Asia, in so many places for whom just the availability of food and water, people who were battling malaria at the same time that they were fighting COVID. And yet our palliative care colleagues, I can tell you, around the world continued their commitment. They continued their commitment to the global field of palliative care, and they rose to serve those people who now were experiencing COVID. For all of our international colleagues, we continue to commit to provide support and to learn from them. It is such a very important time for all of us to be global citizens and in palliative care to remember that palliative care and serious illness care around the world are truly areas that we share. There is so much more that can be done. Another key reflection that I would share with you today is that COVID really broke the illusion that only old, chronically ill people die. In fact, we are all fragile, and what we should learn from this experience of seeing people decline rapidly and die. In my work with LNEC and other projects that I lead, I had the rich opportunity in the early months of COVID to talk with people all over the country and all over the world, people in children's hospitals, in major academic centers, rural settings, nursing homes, and around the country and around the world, as I really listened to the distress and to the pain of the very, very overworked, overburdened healthcare providers. Often they would talk about the 28-year-old who had just come in the ED, the healthy 40-year-old, the new mother, the aspiring young artist or college student, and how incredibly difficult it was to see people move from absolute health, youth, vigor, to now be facing a disease for which they probably would not recover. There are important lessons to be gained. It is an important time for palliative care to think about our future and about all of the opportunities to extend our work into acute care settings, for emergency departments, for ICUs, for urgent care settings, in communities. There are so many instances where people do experience acute illness and decline very rapidly and die. Where are the opportunities for palliative care to make a big difference in the same way that we've improved palliative care in areas that we have focused on in recent decades, such as oncology and heart failure or chronic pulmonary disease? The opportunities are there for us to continue to transform all aspects of the healthcare system and not only chronic illness care. The words on the screen come from Dennis Snower from the opening address of Global Solutions at the World Policy Forum. The words here reflect, at times of existential danger, we instinctively desire to be close to our family and friends, to hold their hands and embrace them. But now we are forbidden to do so. For every act of physical contact, every expression of physical loving kindness and compassion could bring illness and death. We are confronted with the true uncertainty of human existence and the true vulnerability of human life. How often have so many of us believed that we are supreme masters of the world around us? I think one of our great tasks in the months ahead as palliative care providers is to be present as we have an entire healthcare system, an entire community who have experienced such extreme loss, so much personal grief, as well as witnessed the cumulative grief of communities, of families, of clinical settings. And we in palliative care know how important it is to provide the opportunities for people to share those stories. In our LNEC project, we began to host what we call listening sessions, which were simply webinars designed to let people join us and simply tell us a story. Tell us about the patient they had cared for in the last weeks, the person that remains in their mind, in their hearts, and simply to be able to share, to be able to, in a safe environment with other kindred spirits involved in healthcare, to be able to really talk about what it was like to see the healthy person become critically ill, to comfort the family whose wife had just given birth to a child, and yet she probably would not survive more than hours to see this new life. There is so much that we need to do in the months ahead to really help everyone, from our closest colleagues to our communities, to really address all that we have witnessed during this storm. As a palliative care provider, I think most of us have probably spent years really embracing the notion of rituals. One of the things that often sets us apart in palliative care is that we are the people in healthcare that are going into patient rooms, into ICUs, into emergency departments, and asking for that moment of silence. We are remembering religious or spiritual rituals that might be important to patients and families. And so I thought it was really quite profound to come across this article that was written about rituals in the time of COVID-19. It's a beautiful article written about imagination, responsiveness, and the human spirit. Really a lovely article. And the article titled Marking the End of a Life When Rituals Go Missing, again, was one reminder to all of us in palliative care about a time when perhaps we didn't have these moments of pause. This author wrote, "The most profound life cycle rituals are those that mark the end of a life, whether that be a funeral, a burial, a cremation, or a memorial service." Here, COVID-19 pushed us to our limits. Death by COVID-19 changed our rituals profoundly and immediately, depriving the living of any chance to say goodbye or to grieve in traditional ways. With the exception of an acute and unexpected death, such as a heart attack or stroke, family members and close friends are usually at a loved one's side at the time of death, able to stroke a hand or give a last kiss. Not so with COVID-19, forbidden to enter the hospital. In palliative care, we will have many opportunities in the months and even years ahead to think about the rituals that have been missing. Our annual memorial services that have often, again, been a hallmark of the care that we provide and the impact that we have on cultures of care will be ever so important, because now we have literally hundreds of thousands of patients and the millions of family members that are linked to those patients who have not had these opportunities for ritual or a time of grief. Again, another beautiful reflection from this same article about rituals in the time of COVID-19. Couples married 50 or 60 years were separated in death. Adult children could not say goodbye to parents. No family member identifies a body, resulting in a profound ambiguity. And because of the requirements of the shutdown and social distancing, funerals were limited to 2 or 4 mourners. There would be no wake, no viewing of the body, no sitting shiva, no visiting to bring food and comforting hugs to the grieving, and perhaps most important, no in-person storytelling of the person's life. Burial practices changed profoundly. There would be no passing of a shovel to pour dirt on a Jewish grave, replaced by throwing a handful of soil, no washing a body as done in Islam and Judaism. Again, we have lost so much in so many ways. I was thinking about in the years and even decades ahead, in much the same way, just a few weeks ago, we all acknowledged the 20th anniversary of 9/11. And once again, I watched on television and in the news as we heard people tell the stories. Some of the profound images of the babies that were born in the months following 9/11. And those babies are now adults, and yet they reflected on the stories throughout their lives of the loved ones that they had lost. It reminded me of how in the many years ahead, 20 years from now, each of us will perhaps be at the bedside, and one of the questions we will need to ask of people 10 and 20 years ahead is, what was it like for you during the time of COVID? Were there people that you lost? Tell us your stories. Palliative care clinicians are story keepers. We listen to these profound stories, and we help people as they face the end of life to really share those stories, those memories. And for many people, it will be a time of sharing how so many of the rituals were lost. Again, we also know that so many of my colleagues have reflected that COVID has really taught those people who had been ignoring palliative care that we have a lot to offer to the healthcare system. So many people have shared examples of where before the pandemic there had been very little involvement of the palliative care team in the emergency room or perhaps in ICUs. And yet now palliative care teams were being called, can you just come and stay here with us in the ICU or in the emergency department? Because these are settings that were witnessing multiple deaths every day. It will be important for us as a palliative care community to step back and perhaps to reprioritize, because we can't, be everywhere, nor can we be everywhere all of the time. As a palliative care community, before the pandemic began, we were beginning to really have conversations about primary care of palliative care, about the role of the generalist versus the specialist, and how the true measure of our worth would be not only the number of consults we received or the number of patients we saw in a given day, but more importantly, how we as palliative care providers had become change agents, how we now found ourselves being called less and less because, in fact, we had been successful in preparing clinicians across every area of care to enter the workforce, prepared to provide this care. Again, in my own work in the LNEC project, we, a few years ago, began to think about our own priorities because the demands have been so great. In LNEC, we decided that perhaps the best work that we could do at this time was to make sure that we were really getting palliative care well embedded in education systems. And so we increased our focus on schools of nursing. With the support of the Cambia Foundation, we've been able to create standard curriculum on palliative care, a curriculum for all undergraduates and new graduates, and a second curriculum for all graduate schools of nursing. These curriculum are currently being used in over 600 undergraduate programs in the nation and over 200 graduate programs, and we really are just beginning. But that's our vision, that a new graduate would enter the first day of work feeling competent to provide palliative care. I believe very much that palliative care has learned some valuable lessons during the COVID pandemic. We are thinking clearly about our role as the direct providers of care, but more importantly, what is our role to be the visionaries, to be system change agents, and to support all of our colleagues so that palliative care is delivered well throughout every setting of care. Another key attribute of our field of palliative care has been the whole person care that we provide. COVID has been a reminder that illness is not only physical, but it is a whole person experience. It is psychological and is an existential experience. We have been reminded of the importance of spiritual care. I have had the opportunity over recent years to work closely with my colleague, Dr. Christine Polhalski, at George Washington University in their Institute of Spirituality and Health, and to carry out many projects for which spirituality is one aspect of our whole person care. We have realized how important it is when people are facing serious illness, and certainly when people are facing the end of life, to ensure that spiritual care is provided, certainly by our specialists, our chaplains, but that spiritual care also becomes an absolute part of all care by social workers, therapists, nurses, physicians. Everyone should be committed to spiritual care. Some of the first images that I began to see across screens as they were reporting on the COVID pandemic were of the need for chaplains in the ICU and in the emergency department, of the desperate request for spiritual care as healthy people suddenly found themselves in the ED and realizing they would never go home again. This amazing image that you see on the right of the slide was of iPads lined up, this army of iPads ready to be taken room by room, brought back and cleaned and then sent back out to patients' rooms, because these were patients who were receiving last rites or prayers or other religious rituals. Patients saying goodbye to family members by iPad. Images, again, we never could have imagined in our careers. COVID also has taught us a great deal about ourselves. It has taught us that we as clinicians are not robots. We too are humans, and we have to take self-care seriously. I'm sure so many of you felt those early days when all the signs began to appear. Heroes work here. When people applauded, when there was such excitement, there was such a wave of pride that as clinicians, while we were terrified for our own well-being, we also felt this call. How many times in the early weeks did I hear my clinician colleagues say, yes, we're overwhelmed, but this is why we were trained. We were built for this. This is what we do. My ICU colleagues and pulmonary colleagues who said, this is exactly what we know how to do best. We can do this. And we too were pulled into this mentality of, the heroes work here, that we have the ability to hopefully save many lives. And yet it took only days, the first weeks of the pandemic, that we also began to realize that while many people were surviving, the weight of the number of people now, as of this date, over 600,000 in the United States alone who died from COVID. These realities began to take a very important toll on clinicians as well. We began to hear voices of not just, yes, we can do this, I was built for this, to now images of, please, I need a day off, I need a break. I have never, ever witnessed anything like this. And hopefully we will, in the years ahead, reflect on what we have learned about self-care, how to support each other, how valuable it was to have that support. Our colleagues in New York, I think some of the most powerful early images I will always remember were the public, the community going out on their balconies and on their steps in the evening to bang pots and pans and to cheer those healthcare providers for having survived another day. And hopefully we have all learned some lessons and we can continue in palliative care to be the voice of how important self-care is for clinicians across all area of care and absolutely for ourselves. Our palliative care teams have also had a tremendous burden during this time, and we need to think very seriously about how we will debrief and support and plan for the years ahead of how we can also protect our precious commodity of palliative care providers. In reading and reflecting and preparing for this lecture, I came across some work that I'd never heard of before and an author I'd never heard of, whose name is Dr. Walsh, a family therapist. The papers that she's published in the journal Family Process were some of the most profound reading that I have experienced throughout the pandemic, and her words are really, really quite powerful. Walsh wrote, "The pandemic sharpens our awareness of the fragility of life and jolts us not to take future time for granted. The inevitability of losing others becomes more salient. What would we regret? Things unsaid, undone, if a loved one died, or as we faced our own impending death. Loss and threatened loss can heighten appreciation of loved ones taken for granted and spur efforts to repair grievances in wounded bonds. Time does not heal all wounds, but offers new perspectives, experiences, and connections that can help people forge new meaning and purpose in their lives." It's my hope that we as a palliative care community will be brave in addressing the fragilities that we've seen, that we will support the conversations that will be so needed in the months ahead as we share our own losses and vulnerability. We, the healers, need a healing. we need to address all of the things that we have been too busy to face or to speak of, so that we can, in fact, be prepared for caring for future pandemics, for other crises, for the aging population, and all of the demands of our healthcare system ahead. Walsh reflected more on these issues of grief and the challenges that we have in our field of palliative care. She wrote, "Over time, we will need to integrate the pandemic experience into the chapters of our individual and shared lives, strengthening the relational connections that matter to us with the families we were born into, those we chose, and our wider communities. There is no love or life without loss. We are all mourners now, trying to guide one another as we navigate our way forward and strive to make a better world out of tragedy. Our resilience is relationally based, nurtured, and fortified through our interconnections. By facing our vulnerability and by supporting one another through the worst of times, we are better able to overcome daunting challenges, to live and to love fully. The pandemic has undoubtedly changed all of us. It has changed us as people, as clinicians, and we in palliative care have the opportunity to use the gifts that we have, the experience and history that we have over the last 30 years of providing palliative care as we navigate the roads ahead. Walsh also told us that we should be thinking about resilience. We have already seen tremendous examples of resilience, of people who are able to bounce back to face the latest surges, the time that we hoped had not come, but we now live in the late summer and fall of 2021. Walsh said that resilience is commonly thought of as bouncing back like a spring to our pre-crisis norm. However, when events of this magnitude occur, we can't return to, quote, normal life as we knew it. As our world changes, we must change with it. In the wake of the 9/11 terrorist attacks, I suggested that a more apt metaphor for resilience might be bouncing forward to face an uncertain future. This involves constructing a new sense of normalcy as we recalibrate our lives to face unanticipated challenges ahead. There is an opportunity for palliative care as a field, as training programs, as clinicians to bounce forward, to think about what the lessons that we have learned can do to inform palliative care of the future. She concluded that over the ages, individuals, families, and communities have shown that in coming together, they can endure the worst forms of suffering and loss, and with time and concerted effort, rebuild and grow stronger. The painful experiences in this pandemic will require time and shared reflection for meaning-making, questioning and assumptions, and grappling with the fundamentally altered conception of ourselves and our interconnections with all others in our shared world. Taking a systemic view, the pandemic and our response will generate reverberations we cannot foresee or control. Mastering these challenges will require great wisdom and humanity in the months and years ahead. She also said that more than surviving loss or managing stressful conditions, family processes and resilience can yield personal and relational transformation and positive growth. In struggling through loss and hardship, in active coping efforts, and in reaching out to others, families tap resources that they may not have drawn on otherwise and gain new perspectives on life. Similarly, studies of post-traumatic growth have found that individuals often emerge from life-shattering losses with remarkable transformation, gaining appreciation of life's strengths, recognition of new possibilities or paths in life, and deepened spirituality. There are possibilities for our culture to be transformed, for families to be transformed in new ways. That resilience and this new normal we face will inform society as well as our field of palliative care. Walsh went on to just reflect on the old normal and the new normal, and just to conclude here, that as we expand, we will have opportunities for broader systemic changes and with more urgency. I believe very much that the field of palliative care will emerge from this time with a broader, more systemic change for the healthcare system, and hopefully with a greater sense of urgency by everyone to imagine what palliative care can provide to our healthcare system. To conclude, I want to just share a few words from one of my colleagues, Bill Breitbart. Many of you may know Bill as a colleague in our field of palliative care. I've known Bill for probably my entire career. He has been a leader as a psychiatrist at Memorial Sloan Kettering in New York City. Bill found himself, like many of us, quarantined at some point in time and really confined to his own very confined quarters in New York City. And he wrote actually a quite beautiful essay that was published in Palliative and Supportive Care, one of the journals of our field. In this essay, Bill Breitbart reflected on his own family history. He wrote about how he thought about his grandparents who lived in the time of the Holocaust. And he thought about the time that they had gone into hiding because of their Jewish faith, about the fear they faced in the time of the Holocaust. And so as he found himself confined to his apartment in New York, he reflected on his own family history. He wrote in this wonderful editorial, "This COVID-19 pandemic is forcing us to stare at the sun too long. We try to look away, but it is there wherever we attempt to avert our eyes. This death terror is punctuated by episodes of grief and sadness and tears, but it is also punctuated by amazing acts of heroism, compassion, love, humanity, joy, laughter, gratitude, and self-forgiveness." I'm grateful for all of my colleagues in palliative care, people like Bill Breitbart, who shared these words to remind us of resilience, of the positive things that we have witnessed during this time, and absolutely for the future ahead for palliative care. Again, I just want to thank you for inviting me to be a part of this wonderful lectureship series that has become a part of your culture and your leadership at Stanford. I, too, have been inspired by your work and am so grateful to be a part of this tradition, of this lectureship that has continued even during this year of pandemic. I thank you for this time that we share together, and will now turn this program back to Dr. Brenner to share with you some concluding thoughts for this special day. Thank you so much for including me in this time.
Dr. Ferrell, thank you for bringing your depth and breadth of experience through these powerful reflections tonight. It's true that each of us here this evening has likely witnessed unprecedented grief and tears throughout the pandemic. And I also imagine that many of us have witnessed more expansive generosity and compassion. This pandemic has exposed our collective fragility as well as our collective strength. Your words tonight remind us that hardships can be opportunities for transformation and growth as individuals, communities, and throughout our entire healthcare system. These reflections resonate with the vision that inspires this Jonathan King lecture series. It reminds us that serious illness is not merely physical. It involves the entire person, spiritually, socially, emotionally, and existentially. Every year, we seek to bring a lecture that illuminates that vision. By sharpening our awareness of life's fragility, we hopefully will have a greater attention to what matters most, so we can live and care for others more fully. Once again, thank you for taking the time to join this presentation. We wish you well, and we look forward to connecting with you again next year for Stanford's Jonathan King Lectureship. Thank you, and have a good evening.